Health, yeah. This isn't your average health talk. We're asking those awkward questions for you. We're digging into the health, wellness, and medical news that matters to you. We're cutting through the clickbait with facts you can trust, from uncomfortable questions to breakthrough science. It's a dose of real news you can use. This is Health Yeah with Monica Robbins, your prescription for life.
Dr. Miller, thank you so much for joining us. So tell me who you are and what you do.
Absolutely. Thanks so much for having me. I am Dr. Megan Miller. I'm a breast surgical oncologist at University Hospitals here in Cleveland. And what that means is that I mainly take care of women with breast cancer.
So talk to me about, it's Breast Cancer Awareness Month. In your opinion, what are still the biggest misconceptions about breast cancer?
Such a good topic. Biggest thing that I hear in our office is I don't have a family history of breast cancer. Nobody in my family has ever even had a breast problem. Why do I have breast cancer? And we know that the vast majority of patients with breast cancer, this is a spontaneous event, meaning you do not need to have a family history. You do not need to have a genetic risk factor, right? Like a BRCA1 or BRCA2 mutation, a PALB2 mutation, something that we would need testing for or that would like run in our family. Majority of breast cancer cases are sporadic. They don't come from anywhere in particular, right? There's lots of research going on into why do we still get breast cancer and could there be a vaccine for breast cancer and things of that nature. But everybody needs to get screened for breast cancer, whether you have a family history or not. If you're a woman and you're age 40 or older, please, please, please get your mammogram once a year. And if you do have a family history of breast cancer or you have other risk factors for breast cancer like dense breast tissue, or you've had atypia, a biopsy showing atypia, a surgery showing something of that type, please get in touch with a breast-specific provider. Your primary care doctor can help refer you so that we can help guide your care.
There's still a lot of mixed messaging coming out about when women need mammograms. Can you clarify it from your perspective? Because you're the one who sees breast cancer on a daily basis.
Yeah, a great question. I do think there's confusion still around that because there have been different guidelines over the past 10-ish years. Some groups have had different ages at which we start and different frequencies at which we should get them. But the standard from the American Society of Breast Surgeons, which is, our national group, we take care of most breast cancer patients in our country, and backed by the American Cancer Society, is a mammogram starting at age 40 and annually thereafter until your life expectancy is such that it doesn't make sense to get mammograms anymore, right? So there's not like an age, right? It's not like 75, it's not 80. It's when your life expectancy is probably less than 10 years, or if you had a breast cancer diagnosis, you might choose not to treat it.
Talk to me about what's different in breast cancer care these days.
So many of us, have a lot of fear around breast cancer and what is that going to mean for me? Am I going to die from breast cancer? Right. And I would say majority of the time nowadays, we have a very early stage of diagnosis. If we are getting our mammograms, as we just talked about, early and regularly, most breast cancers are found at an early stage, meaning we find them on a mammogram or an MRI, some type of a screening test. The minority of breast cancers are found through an exam, right? Either your own self-exam, which I should mention, those are also incredibly important. Women should be doing a monthly self breast exam. Usually recommend just doing it at the same time of the month, right? Some people will say I do it when my period starts. Some people will say I do it on the first day of every month. It doesn't matter as long as you do it once a month. And then you should be having an annual exam either by your primary care provider, your OBGYN, or one of us in the breast specialty. All of that to say that because we have good screening, most breast cancers are diagnosed very early, and that means they're all treatable. All breast cancers are treatable, and most breast cancers are curable, meaning that this is going to be a contained diagnosis, right? This is not going to be something majority of the time that threatens your life. We have such good treatments nowadays. I mean, almost every breast cancer now still requires surgery, but many fewer require chemotherapy. And I know that's a big fear out there, right? Am I going to have chemo? Am I going to lose my hair? Am I going to get really sick? Am I going to be able to take care of my kids? Am I going to be here for my kids? All of those things are incredibly important concerns. And I can tell you that we do give chemotherapy when it is needed, but to so many fewer women than needed it in the olden days, right? In the olden days, we're only like 10, 15 years ago. And same thing with radiation. Many breast cancers do require radiation, but some of them don't. And women have lots of choices about which type of surgery they can have, as long as we have early stage disease, right? The higher the stage, and there's certain what we call receptor subphenotypes of breast cancer that do require chemotherapy and more immunotherapy, more sort of targeted therapy. But all of that being said, we have such great advances in the field that we don't need to be scared of breast cancer. We just need to get it treated.
I'm so glad you brought up self-exams, because that was another issue that a lot of people are saying you don't need to do those anymore. Your advice, though, to women with dense breast tissue, would you recommend that they start talking to their doctors about getting MRIs instead of mammograms? And are you still encouraging every woman to do that regular self-breast exam?
Super, super good questions. And I think that's a big question mark, right? Because we can address the self-exams first. The common complaint that I hear from women, right, is, oh, it's so lumpy bumpy. Like, I don't know what I'm feeling. So that is sort of the idea of the self-exam, is that you get to know your own breasts. Yes, they may be lumpy bumpy, but are they lumpy bumpy in the same way each month, right? That helps us to know whether there's a change. And that's really what we're looking for, is like a detectable change. Breast cancers in general will present as like a hard nodule, something that is distinctly different than the normal breast tissue that we kind of, are used to in the lumpy bumpies. Or another symptom, right? Nipple discharge that is spontaneous, meaning unprovoked, that can be bloody, and unilateral, meaning just on one side. Those are like red flags that something could be going on. Also, something on your skin, a rash that doesn't resolve, like maybe you've gone to your PCP, you've gotten some antibiotics, and it's still there. You need to get that checked out by a breast specialist. So there are some things on self-exam that I think women can bring to our attention. Something like a lymph node under the arm, or like, if we don't know that it's a lymph node, right? Like a bump under the arm that's not going away, and it's not just from like razor burn, right? Those are the types of things that you can find yourself that we want to know about. So I would still encourage everyone to do a self-exam monthly. And if you have a concern, bring it to the attention of your provider. And then with respect to the dense breast tissue question, nowadays a lot of women, especially locally, are going to be seeing on their mammogram reports something about you have dense breast tissue. And it will even, some of our radiologists and at UH, this is a relatively newer part of the read, but it will calculate the lifetime risk of breast cancer at the bottom of the report based on a risk calculator called Tyrer-Cuzick, or the Gale model. And that's actually based off of the information that you as a female give to the radiology department before your exam. So you'll be asked these questions about, how many pregnancies have you had? At what age did you start menstruating? Have you breastfed? And the reason why we're asking all of those questions is to get a sense of what your estrogen exposure has been, because some of those can increase our risk of breast cancer. And so those questions, in concert with the breast density, which is calculated based off of the imaging, the radiologist themselves has to do that part of it, will give us a score. And that score, if it's above a certain number, like 20%, actually puts us in a higher risk category for breast cancer over our lifetime. And if that risk is above 20% in general, there's certainly some caveats, we will recommend supplemental screening with an MRI. And the reasoning behind that is that dense breast tissue can hide breast cancers, right? When you're looking at a mammogram, the fatty tissue is more black and the denser breast tissue is more white. And cancers are also white on mammograms in general. This is all, very sort of surface level. But the denser the breast tissue, the harder it can sometimes be to detect a breast cancer. Now, this does not mean that mammograms are no good. It just means that we might need something in addition to our mammogram. So get your mammogram. And then if it turns out that you do fall into an increased category of density or an increased risk of breast cancer based on, again, some of those things that I just mentioned, and family history goes into that equation, then we may want to get a supplemental MRI.
From your perspective, I remember years ago, nobody ever talked about breast reconstruction. Now it is part of the traditional treatment discussion.
Yeah.
What options are there relating to reconstruction, and have they changed?
Love this topic because it really shows how far breast cancer care has come. And I think one of the misconceptions here is that reconstruction is elective. It is elective, meaning that women who are offered a mastectomy are offered reconstruction. So there's a choice there, but it's not an elective cosmetic procedure, meaning your insurance company, as long as you have insurance, is mandated by law to cover any procedure having to do with breast cancer or breast reconstruction when it's related to breast cancer. So let's do like two quick examples. One might be, let's say you're a larger breasted woman and you end up having a small cancer and you are offered a lumpectomy or a mastectomy. Lumpectomy meaning just take the cancer out, mastectomy meaning remove the whole breast, right? But if you were to have a mastectomy, you'd be pretty mismatched, right? Because your other breast is large. So you might want to consider having the lumpectomy and what we call an oncoplastic reduction, meaning like a breast lift reduction kind of thing on your cancer side. But that same symmetry procedure is going to be covered on your non-cancer side so that you are not left lopsided, right? I mean, we have to be sort of, attuned to not only our cancer outcomes, but our cosmetic outcomes, right? Because we all still need to function in the world, and we hope that women will still have some, if not at least comfort in their bodies, but ability, to still feel like themselves. So there's one option. And another option is that after a mastectomy, meaning we do need to remove the entire breast, we can do two basic types of reconstruction. One we call implant-based, which is sort of what it sounds like. I think we're all somewhat familiar with breast implants, but the breast implant is not being put in as like an augmentation to make your breast larger. It's literally to replace the tissue that was removed. And if a patient, for symmetry reasons or for breast cancer reduction reasons, decides to do that for her other non-cancer side, that is also covered by insurance. So a bilateral mastectomy with reconstruction is a totally viable option. It's a decent amount of surgery, so some counseling needs to be gone into that conversation with some shared decision making. But that's all 100% covered, and also some people call it a flap surgery or a tissue transfer surgery. Essentially, we can create a new breast for a patient by using her own tissue, usually coming from either her belly or her back. Much more involved procedure. But it does allow a patient to use her own tissue. Your surgeon should talk to you about all of those options. There are certain cases in which a mastectomy is going to be recommended based on the size of the cancer, the stage of the cancer. But just because you have a breast cancer does not mean that you need to have a mastectomy to treat your cancer, to cure your cancer, to save your life. Most of the time, in an early stage situation, we can perform a lumpectomy, and then you get to keep the whole rest of your breast.
What do you see on the horizon relating to treatment?
Overall, we're going to be doing less of everything. I think because our treatments are better and they're more multidisciplinary and more individualized, there's not a one size fits all solution. So your breast cancer, if you have breast cancer, if you've survived breast cancer, is probably different than the breast cancer of your neighbor or your sister or your friend or your, person on Facebook, right? And so I think definitely having those connections and hearing other women's breast cancer stories is really important, especially if you're newly diagnosed or you've just been told you need a biopsy or you got called back from your screening mammogram. Those are all really scary situations, right? Because we don't know what the outcome is going to be. And so, of course, all of us are going to Google, or, look things up on the internet. And it is important to have social connections and to know what you may be looking at. But I would caution all of us as women that breast cancer truly is different. because of the size, the stage, whether your lymph nodes are involved, the type of cancer that you have. Is it lobular? Is it ductal? Is it ER positive? Is it HER2 positive? Is it triple negative? There's all of these different varieties, and those characteristics tell us, your treatment team, what to do for you, how we can cure your breast cancer, right? With, like I had said, surgery, chemotherapy or immunotherapy or medication that blocks our hormone receptors, radiation. Those are all within the realm, but just because somebody had all of those things doesn't mean that you are going to need all of those things. And there's a lot that we do nowadays to mitigate the unpleasant side effects of some of the treatments. So just because you're recommended for chemo doesn't mean you're going to lose your hair. We have this great therapy now called a cold cap, which is like kind of what it sounds like. It sits on your head while you're having the chemotherapy, and it can really reduce hair loss. So I think some of the things that we worry about having to do with breast cancer treatment are going away. I wouldn't say they're myths, but I would say there are much better approaches. And so it's not, I don't think it's as scary of a diagnosis as it used to be. And just remember that here in the city of Cleveland, we have amazing medical institutions. We have really, really great medical care. And so there's great resources out there, whether you're on the east side, the west side, the south side. There is probably a breast cancer center very close to you, and we're all here to help you through this journey.
And I would like to say that breast cancer awareness is not just the month of October. It's
so
every
true.
month.
So true. I mean, again, those monthly breast self exams, October is a great month. If you haven't gotten your mammogram, go ahead and make an appointment. There's still a whole week left in the month. And if you can't get in this week, get in, in November. But get in before the end of the year when your insurance deductible, switches over. And we would love to see you at any of our breast centers and be partners in your care.
Dr. Miller, great advice. Thank you so much.
Thank you, Monica. Take care.
Thank you so much for listening to Health Yeah. Remember, you can watch the video versions of the episodes on YouTube at Monica Robbins' channel. Subscribe and follow my work and never miss an episode at author.com/Monica Robbins. Find me on X and Instagram at Monica Robbins, and I'm also on Blue Sky Social at monicarobbins.bsky.social. And you can follow me on Facebook at Monica Robbins, WKYC in parentheses. Wishing you the best of health, and stay tuned for your next dose of information.
Monica Robbins is not a medical doctor. All content presented in this program is for informational purposes only. It is not intended to be a substitute for professional medical advice and should not be relied on as health or personal advice. Always seek the guidance of your personal doctor or qualified healthcare professional with any questions regarding your health or medical condition. Thanks for listening to Health Yeah with Monica Robbins from WKYC Studios. Subscribe now so you never miss an update, and find more on everything you heard right here on WKYC.com, the WKYC app, and WKYC Plus on your smart TV.